Ladies and gentlemen, welcome to the webinar. I'm honored to shed some light on platelet-rich plasma biologics and touch a bit more on the use of PRP in aesthetics. Like Alicia mentioned, I'm Chief Scientific Officer for MSci Corporation, as well as the Executive Director for Gold Coast Biologic, which is a training and scientific institute from which we do a lot of scientific training, because we feel with all the developments in applications for PRP and other biological uses, that there's a need when we look at the long list, as you see here, from different medical areas where biologics like PRP are being used, then that's a list that's continuously growing. Got started in the 80s with use in cardiothoracic surgery, shortly followed by orthopedic surgery, the use for PRP in chronic wounds, and then just follow the list. And you will see on the right-hand side as well for aesthetic medicine, hair transplantation, facial rejuvenation, men's and women's wellness. And just to refresh your memory, for those of you who have no idea on the PRP technology, the basis is a unit of whole blood, a unit of fresh whole blood, autologous blood. You acquire that from a patient through a venipuncture in the syringe, and when you look under the microscope, you will recognize the various blood components, like red blood cells, a variety of white blood cells, and of course platelets, and that's in the volume of plasma. Devices, which we call PRP devices, centrifuges, are capable of concentrating the PRP, the whole blood volume, down to a PRP volume by the technology of MSci Corporation. Up until now, we have two different devices which we feel create a PRP that is really rich in platelets, that has a rise in white blood cells, and we're going to address that a little bit more in a minute. And as you can see, the aspect on the microscope from whole blood to PRP is a completely different aspect. And when you follow the eye of use, ultimately you will have available in your syringe a small volume of plasma with a high concentration of platelets. Depending on the protocols you have been using with the centrifuge, you will have a certain amount and certain differentiation of white blood cells with a minimum of red blood cells, as you also can see on the blood smear. One of the components you will have in there, and we're not going to discuss them anymore, would be the growth factors, platelet-derived growth factors, as we call them. On the screen you see now the most well-known growth factors that are present inside the platelet structure. You see abbreviations like VEGF, vascular endothelial growth factor, transforming growth factor, and each of these growth factors, they have a specific task. So when the growth factors ultimately are released, because you take them out of the bloodstream, they're in an anticoagulated medium, you centrifuge them, you have them concentrated, and ultimately the goal is to deliver them to a recipient side, to a new microenvironment. And in that environment, what you're going to see is that these growth factors are released on the platelets, and they will find on the outside of the various cell membranes their dedicated receptor, and that's the moment actually where the cell signaling is going to start, and where regeneration, healing cascades are being initiated. Please remember, since you're working with a volume of blood, that apart from the platelets, you collect a lot of other cytokines, chemokines, and proteases. And all of these, well, proteins, they have different functions. So apart from the fact that you are injecting concentrated platelets, you're also injecting a variety of proteins and cytokines that, well, normally under normal conditions work very closely together with the total content of the products present in your bloodstream, but then in a concentrated manner, and they should be able to do their task in the new environment. So how does the market look like? This is just a simple picture indicating the variety of devices that are on the market. And I lost counting, but I think we are close to 34 different devices on the market presently. That's quite a bit. And all of these systems have different IVUs. They are creating different products. And what's really sad, what we forgot as a scientific institution and clinical researchers is to come up with a standard for PRP therapies, because we have so many different devices, we have so many different solutions for anticoagulation. Actually, it's almost impossible at this stage to get consensus with the scientific community in order to standardize these procedures. So the literature really had a great look into it. So there are plenty of papers published addressing the different compositions from PRP. And I just want to point out that what you see here, the so-called test tube PRP kits, that is not what we call PRP. PRP has a very, very clear definition. And the definition is you should have an environment that has a lot of platelets. So a product that has a low platelet concentration, low platelet numbers, equals what we would call a poor quality PRP. And what you're going to find is little to no treatment effects. And actually, it's going to be a very expensive product, because the definition was produced in the 80s, is platelet-rich plasma needs to be rich in platelets. And I'll show you in a second here that if you do simple calculation on the volume that you would like to work with from the test tubes, let's say 9 millimeters of blood on an average patient that has 100,000 platelets, and from the test tube you will be able to get 5 mils of PRP, so to speak, with the efficacy of the protocols from a single spin device, the non-availability of creating a solid buffer coat, so the single spin, and you do some calculations with these parameters, and you will see that the platelet concentration factor for these kind of devices, and again, they vary a little bit, but when this typical example for brand X would be an increase in platelet from baseline from 0.8%. And just by understanding the math behind it, you will see that that's a different product than what we would call a platelet-rich plasma product. And there might be variations based on how efficient devices are, but the platelet yields that can be achieved by this technology is anywhere between 40 to 50%. But also be aware with regard to the other devices, you will have differences also among the so-called two-spin devices. And we published with it, we published with others about it, clearly indicating the huge spread in in outcome for these products, just indicating how difficult it really is going to be to come up with a standard. So there is one other aspect that I just want to mention briefly to you, and that is the choice of anticoagulants. This paper really demonstrates clearly the anticoagulants that are available on the market. Sodium citrate, EDTA, ACDA, and these anticoagulants are used with all the devices to concentrate blood, with the PRP devices, with the plasma PRP devices, inside the tubes, they all need to have some kind of an anticoagulant. Otherwise, when you do the blood draw, the blood will clot during during the blood donation. So research has been done and looking at what are the effects, because these are different molecular compositions. And one of the conclusions was, before going into detail, is that you definitely would like to have a product that has sodium citrate as an anticoagulant. Obviously, the sodium citrate has been proven in a lot of laboratory analysis that is the best preservative for the blood components with regard to MSC proliferation, the stem cell proliferation, and the preservation of platelets. So depending on the choice you have for a system, you definitely want to make sure, if you have a choice, to choose for sodium citrate, as this would be the most friendly to the blood and to work with outside the bloodstream. And that's one of the reasons why AMSI choose to have this product, this anticoagulant, in their kits available. Another, well, different area I just want to mention to you and create a little bit of an awareness that, as you can imagine, different tissues like soft tissue, tendon, bone, or even with man's wellness for erectile dysfunction, all of these specific tissues, they have an optimal dose response. In other words, tendons tend to have a higher response to PRP therapy when we have more platelets, a higher concentration of platelets than for soft tissue. And bone has, again, another concentration to get to the optimal outcomes for the therapies. So in other words, there is no generic PRP, and what you would like to do is you really tailor your PRP dose, your concentration, depending on what you would like to treat. And that's the same in aesthetic use. The aesthetic PRP creates a better and more forceful result at a certain concentration than when you have a PRP at a very low platelet concentration. So make sure that you are aware of these variabilities in tissue responses by using different devices. Again, questions come up all the time looking at nomenclature. So even on terminology, it seems to be quite difficult. And PRP is, well, the biggest name we have, but from there on, companies start to produce different products, and they tend to move to different names like PRF, platelet-rich and fibrin, platelet-rich and growth factor, autologous concentrated platelets, platelet fibrin sealant. You will find a lot of different names. Actually, what the majority of these papers and devices would like to create is a product from which you can, well, hopefully digest what it really means, and that should ultimately contribute to get to better standards. But this has also been recognized in the systematic reviews that what we really need is some kind of clarification on the formulations. The same here for how many platelets do we need? That's a very good question. And the answer to that is, well, we slowly start to understand for the last couple of years that there is a minimum of amount of platelets that we would need to have per microliter. So the above paper here really reflects the experience of Dr. Marks in maxillofacial surgery with PRP. He did a huge review of his patients, who did well, who had a modest result, who had no results. But the patients he has been treating with platelet concentrations of 1 million per microliter all had a good result. And that study was confirmed a couple of years later by another study, although in orthopedics, but it clearly indicated as well that a certain amount of platelets would be needed in order to make a clinical significant effect. Then this study came out not too long ago in 2015, supported by the study from Lopez, and they have been looking more closely on, well, what would be needed to get to angiogenesis, neoangiogenesis, when using human endothelial cells. So they did a dose response study, and obviously the optimal concentration being capable of inducing angiogenesis would be a platelet count of 1.5 million per microliter. And based on reviews done for meniscal tears, tendon injuries, and other areas of poor vascularity, the number of platelets should be high. In other words, the platelet counts of at least 1 million per microliter have been confirmed from systematic reviews looking in the MSK field when angiogenesis occurred, or at a later stage when healing was confirmed. So looking a little bit at the white blood cells, as you know, we get a variety of white blood cells.
Dr. Everts, excuse me, I'd like to interrupt you very quickly. I apologize, but we have a good question, and I feel like I'd like to just ask this question at this juncture, if that's okay with you.
Please go ahead.
The question is, recently, reps for Regen Labs USA visited me and did a demo of their PRP process and product. They seem to be the new PRP kid on the block. Simply stated, for $89, their procedure can produce 5 mLs of PRP at only 1.6 to 1.8 times. Their argument, stronger is not better, and their strength is perfect. They referred to a recent level 1 randomized controlled single-centered trial using their product, reported in Arthroscopy, the Journal of Arthroscopy, and I can send you that information. It concluded intra-articular injections of leukocyte-poor PRP can provide clinically insignificant functional improvement for at least 1 year in patients with mild to moderate OA of the knee. Comments, please, on Regen Labs PRP and on the study. So I'll have Dr. Wilcox send me the study, and I'll send that to you, Dr. Everts. But if there's anything you can speak to that, that'd be wonderful. Also, the second question is, what about using heparin as an anticoagulant?
Yeah, I'm not surprised, to be honest. Especially when you look at osteoarthritis. There have been plenty studies published, and we are now even looking at the level of systematic reviews. The systematic reviews come with a couple of conclusions. One of them is that the review revealed a effective platelet therapy in these patients for at least 4 to 5 times the baseline. What is important in OA is to understand what the grading of OA is. Grading 1, 2 are outer stand 3 and 4. I do understand that plasma by itself has an effect on inflammation, but that was only a temporary effect instead of an effect that really calms down the inflammation at that time. So, well, I'm happy to hear there are more devices capable of doing that, but for now, I would like to stick to the bigger series that have been published, indicating a different pathway for the bioformulations of PRP. On the heparin part, I'm not quite sure whether it's going to be pure heparin that has been used, to which concentrations. I know heparin works pretty well for mesenchymal cells from bone marrow aspiration, and the platelets in that medium function well. They maintain their functionality. But I'm not aware of any studies just using heparin, and again, what kind of a concentration to preserve the platelet function. So that's something I definitely would be interested in understanding. If anybody can come up with that information, that would be great. I would like to continue with...
Thank you very much for answering those questions. And we do have one more, but the Regen Lab PRP is only 1.6 times baseline.
Yep. That's yeah, that's correct. There is no other way. If you understand the mechanism of a single spin procedure, Then the big difference with two-spin devices is that the two-spin devices create order to the chaos these single-spin devices do. When you measure the platelet numbers in in the actually plasma layer, and you look at the platelet numbers in the red cell layer, which they do not take into account, then platelets are still all over the place because it takes time, it takes centrifugal forces, that density separation in order to have the cells layered to concentrate. That's only being done at certain G forces for a certain period of time. And 5 mL at 1.6, that would indicate an efficacy of the device of getting close to 80%. Because keep in mind, to make the calculation, 9 ml blood to 180,000 baseline, and then 5 ml having 1 times 6 times that concentration would indicate a very high yield of platelets in 5 mLs, even for the 1.6. So yeah, it's not a surprise. It's still low, and I would say this would be a lower now on the high side.
Thank you very much. Thank you.
Thank you. So the white blood cells, in your textbooks from the early days, you will see all these different white blood cells. They have their own specific functions. The minute you're going to put the whole blood in a centrifuge, the basophils and the eosinophils are not going to survive. Their cell membranes are very fragile, they rupture, and their content is being released. So when you do the lab work, you only will find the neutrophils and monocytes and the lymphocytes. Neutrophils are the one that everybody discussing about. You don't want to have them. They cause inflammation, so you don't want to inject those in an area that has inflammation. So you would like to have a product like the MSAT product where you can use different formulations, either to add the neutrophils or to eliminate the neutrophils. I'm not saying neutrophils are bad. Neutrophils are good in certain conditions and bad in other conditions. But you should have the flexibility in, well, have the choice for your formulation of PRP to have the neutrophils in there. Right now, I would like to spend a couple minutes to address the presence of one of the white blood cells, the monocytes, in the PRP. I encounter a lot of discussions on PRP, on platelets, and on neutrophils. To a lesser extent, and we're going to address that in a minute, the red cells, but let's stay focused on the monocytes for a bit. Monocytes are produced in a red bone marrow, released to the systemic circulation. They circulate in your blood. You can find it in your lab work. What's happening with the monocytes is that if they encounter an area that is deprived of healthy cells, if you have an injury, the monocytes convert into so-called macrophages. That's where most of the knowledge and most of the understanding really stops. But when you look into different journals, when you start to look at, well, what are monocytes capable of? The monocytes are really capable of, again, producing these macrophages, but macrophages by themselves, they have different phenotypes. And one of the phenotypes is creating a non-inflammatory inflammation. So they do a natural debridement, and when they recognize in that area where, let's say, tissue regeneration is needed, where you have a deprived area or fibroblasts, where you have scar tissue, and that has been cleaned by the monocytes, type 1, they will convert into type 2. And that type 2 is a very important one, as we understand only very recent, because the type 2 macrophage, again, originating from the monocytes, present in your PRP, they have a huge regenerative capacity. So the combination of PRP, where the growth factors and other cytokines have a good regenerative capacity, we are still looking into right now what it means, what the contribution of your monocytes is in your PRP to work synergistically with the platelets in the PRP and the other cytokines in order to understand the full potential of of the white blood cells in your PRP. So where others make a choice for a completely white blood cell free PRP, certain PRPs that are capable of capturing the monocytes at a higher concentration, they tend to be in an advantage. And actually, this picture really shows it all. With the technology of MSite, the disposables being used, depending on the protocols you're going to use, you will be able to capture that buffy coat layer, including the monocytes, and in this case, without the inclusion of the neutrophils. So you are able to capture platelets at a high concentration and the concentrated monocytes, and that ultimately will give you what we call a PRP formulation that has different characteristics, and that's a different world than the PRP that's being used in a lot of studies, like you see on the left. So there are different kinds of PRP where you're really interested in would be the clinical PRP. You want to have a PRP that's being used in a clinical setting, not in an animal setting, and that's going to make a clinical significant contribution. So where are we looking at? So what you should understand is by using different formulations that you can accomplish from a unit of whole blood using MSite PRP devices would give you, depending on the type of device you use, a significant amount of platelets, anywhere between 4 to 11 billion 4 milliliters. They have tissue regenerative capacities. You have the option to work with neutrophils. You can leave them where they are if you don't want them. And for one thing for sure, you will have regenerative capacity simply because the yield of monocytes is significantly high, as well as the lymphocytes for immune suppression. The other big thing is you don't want to have red cells. You should try to keep your hematocrit down to 1% or even less, because that's another discussion. And I just want to mention, having red cells in your PRP is a bad thing because it will create inflammation, it will cause cell death, it will lead to microcirculatory problems. Actually, the opposite of what you would like to achieve with these injections. So depending on where you are, what kind of medical field, what your treatment goals are, you have different injection techniques. So you can make a topical graft, you can inject it in your wound beds and open wounds, you can inject it into joints, you can mix it with other stuff, in this case, for facial rejuvenation with fat, with adipose tissue. You can use it for bigger surfaces intraoperatively with aerosol. For man's wellness, you can use it as a small boluses, and you can inject it in your scalp for hair. Just a quick couple minutes on the study we have recently completed and has recently been published, and it's a study addressing the pure PRP in highly selective patients. This was the study layout. We did a lot of techniques for objective measures and a lot of instrumentation to measure the effects of 3 PRP injections over a period of 3 months with a 6 months follow-up. So we had the objective measure with the instruments, and then we had the self-assessment from the patients. These were the questions they were asked, and we wanted to give them answers to. And these are just a couple examples as what the results were on these studies. So we had a highly significant decrease both in the number of wrinkles, the wrinkle count, as well as in the volume. So that has been assessed in the study. We use subepidermal ultrasound to see what's happening in the so-called SLAP, in the low echogenic band under the skin. And what you see from day 1 as a starting point is where we are 6 months after we started therapy is a completely different aspect of the skin. So you, without really pointing out what are the red cells, the collagen, and the yellow or fibroblast, the aspect is changing. The total cellular structure change after the PRP, 3 months after the third injection, significantly. So we dove in it a little bit more just to understand maybe we created subcutaneous fat. That's not something you wanted. So we were able to measure the subcutaneous fat composition, the thickness, and it didn't change. So what we saw was a change in the density. So the density really changed significantly as the slab, the band where there are no cells present, decreased significantly. So this was a great finding that we're very happy with. And there were way more findings. So I'm sure Alicia can give you the paper if you want it. Again, these were the questions, and looking at the starting point and looking at 3 months after the third PRP, 6 months after the first injection, and these were the answers from the patients, how they evolved over time after the PRP. And these figures here were fully in accordance with the objective measures that we took. So these are the summaries. So we had a decrease in brown spots, decrease in wrinkle count, the firmness in the nasolabial area, the redness, and the low agentic band thicknesses were all positively affected by the use of PRP. So what's my takeaway here for the PRP? And this is my last slide. We see a tremendous increase in the use of PRP in clinical practices. There seems to be continuous growth in science, but also to come up with the science to the level of systematic reviews, we're still behind. Different PRP devices, they all claim to produce PRP, but please stick to the definition and thing on clinical PRP, as clinical PRP has clearly advantages with regard to the number of platelets, with regard to the presence of the monocytes, and lacking red blood cells. So that clearly should have a positive effect on the different indications, and you should be able to work with these different formulations. It's important to understand that PRP by itself is not the only working power here. As you collect platelets and other cytokines, we see great outcomes in aesthetics, whether it's facial, whether it's hair regeneration, but we are still missing the level of the systematic reviews. So more studies need to be done. Be aware we got different way of delivering the PRP, and one thing for sure, we do not want to have red blood cells in there, as they do not contribute to any form of tissue regeneration. So this was just a very brief summary on a more extensive workshop Gulf Coast Biologics is going to host. Dr. Vuich, the next presenter, will be there to show on live models her technique. We're going to go more in detail, but for now I would like to introduce Dr. Lisa Vuich and share with you her experiences so far. Lisa.
Thank you very much. Okay. How are we looking?
Looks great, Lisa.
Okay.
Looks great.
All right. All right. Thank you so much, Dr. Everts. That was excellent. So for those of you who don't know me, as Alicia had mentioned, I own Renew MediSpa in southern New Hampshire. I was originally in internal medicine and started doing aesthetics back in 2005. By 2009, had sold my medical practice and really do full-time aesthetics at this time, all different types of procedures and facial injections. So, oops, can I go up? Hold on, I'm not used to this. Hold on, we got to control the screen here. All right. Hold on, well, I'm going to keep talking while you figure this out, Tammy. So, I was fortunate back in I think it was around 2014 when I started incorporating PRP into my practice, into my aesthetic practice, that I had fallen in with the EMsite system, the MSite group. I still have a test tube system also. It had originally been Eclipse, and then that got changed to Helion. So I do have both systems here, but we don't use the single spin test tube system for our other level procedures. Oh, hold on, I'm going to try to advance this slide here. We're just having a little difficulty with it. Okay, so one thing, over the years as I was doing PRP procedures, and a lot of these included either procedures for thinning hair, but also quite a few sexual wellness procedures, O shots, P shots, terminology often used. After a few years of doing this, I started to ask myself more and more, why do some patients do so remarkably well and others do just okay, and others seem to have little effect? Even if you sort of pair patients in your head and think, well, they had about the same complaints at about the same severity, they were about the same age, about the same comorbid, contributors there. So I started to get interested in whether there might be a way to actually measure what we were injecting, because our techniques were the same, our process was the same, our PRP, we thought was the same, and we knew we were using a really good quality system. So I had started doing some web research on getting a platelet counter, because I thought, well, let me test the platelet count on what I inject before I inject it, and maybe that will reveal something about why patients seem to do differently with the same procedure under similar conditions. So in the course of looking for a platelet counter, I came across Bridging Biosciences, Mr. Tapley Holland, and they, to make a long story short, they were able to bring in to Renew a platelet counter, but also a software program that they were developing that would help us predict how much blood draw we would need in order to get to our goal PRP concentration, because we knew, as Dr. Everts had pointed out, that we wanted to be able to know, if possible, that we were hitting that 1.5 million or at least over 1 million. And, up to this point, we were flying blind. We had no idea what we were injecting. We were just drawing the blood, prepping the PRP, and throwing it in. So we've been helping Bridging Biosciences develop this a little bit more, just fine-tuning the software really. But I'm going to go through a few slides that explain exactly what we're doing, and I'll give you some overall general impressions of what we've seen change. So what this Transcend PRP protocol involves is that before we actually draw the blood that we're going to prepare the PRP from, we do a pre-draw finger stick for determination of the patient's platelet count. Our dose target in this protocol that we're using is 1.5 to about 2 million cells. Validation after centrifugation means that we retest prior to injecting the actual PRP. So we're doing a platelet count by finger stick initially. We're documenting that. The software is telling us how much blood to draw in order to get to our target. And then we are also documenting the dose in terms of the platelet count of the PRP that we inject. So that's the basis for this, and this is an IRB study that's in progress here at Renew. Let me just hit that again. So this is a slide from a little while back. I think it was last summer, primarily looking at O shots and P shots, and primarily using the MSite system. And what we found there is that the average baseline platelet count of the patients we were testing was around 165. So it wasn't even 180, it wasn't even 200. The average was 165. The average calculated or recommended volume, according to the software program, was 77.4 mLs. So in other words, we were being consistently directed that if we wanted 7 to 10 mLs of PRP at 1.5, let's say, million platelets per volume, we were going to have to draw 77.4 mLs on average, about 83% of the time or so. So this really opened our eyes, because before we were doing this, we were doing lower volume draws than what the program ultimately was directing us to do. So we did, start working with the program and start doing larger blood draws. Fortunately, with the MSite system, we have the option of doing a 60 ml draw kit or a 120 ml draw kit, and the cost difference between the two is minimal. So it doesn't really cost us much more to do a larger blood draw at all. So again, we felt that this was showing us we really have about an 88% improvement opportunity in terms of the dose of PRP that we're delivering. This IRB study is still in progress. Currently, there have been some other sites across the US that have been recruited to participate as well. And I'll just show you a couple pictures here. This is one of my medical assistants, Danielle. The platelet counter is to the left, and then there's just a laptop there that we work off of. And what she's doing right there is processing a finger stick sample so that the system will measure the patient's platelet count. The screen then, that's the screen where we're told what the platelet count is, number of platelets per nanoliter. Once the device has read 2 slides. And then it takes us to a screen where the software has determined for us, based on, for example, that person's platelet count on that particular day, and based on, let's say, we were doing an O shot, and the system knows we want 7 mLs of PRP at a target of the 1.5 million or more. Then knowing all of that and knowing we're using the MSite system, it says that your desired aspirate volume is 46 mLs of whole blood. The number below that, the 57.5, is just the software doing a calculation of 25% more than the original recommended volume, just in case someone wanted that as a fudge factor and they wanted to, draw a little extra or have a little more just in case. So the number we primarily go by is the one at top, which is aspirate volume. And then lastly, we take a small amount of the PRP once it's created, and that is then again, as I said, tested to determine what the actual dose of platelets in the PRP was delivered. If the software finds that we're too high, if we're in the 3 million range, it will give us a dilution factor. So it will tell us if you want to bring it back down, this is exactly how much platelet poor plasma you need to add back to your sample in order to bring the concentration down a notch, if you feel that super high concentration might be detrimental in some way. The next thing we're adding in terms of combination with PRP is peptide therapy. Some of you may have started to hear about peptides and pharmaceutical peptides to improve growth hormone, peptides to improve tissue regeneration. And we're certainly starting, actually just since this past fall, incorporate this into our practice. And I'll mention in particular the study that we've also started this month, which is an IRB study with respect to hair loss. So this is a protocol for hair regrowth, which is combining platelet-rich plasma using our double spin system and pharmaceutical peptides. These are peptides that some are used during the actual microneedling procedure and PRP injection, and there are additional peptides that the patients will take home and be using through topical foam application, and also there's a schedule of self-injection of thymosin beta-4 to also improve tissue regeneration. So preliminary studies are underway. It's a 12-week study, and we just started in January. So we'll need to stay tuned. We'll get back to you we're doing lots of photographs. And here at Renew, since we have the Transcend protocol up and running, we are using that with our hair study patients. So in addition to being able to use photo documentation, we will be also reporting back to the study directors about what our dose of PRP delivered was for our patients at least. I'd like to mention also, in case there are people in the audience who do aesthetics, I am doing more and more combination therapy, mixing PRP. I'm sure many of you already do that in combination with filler, but also in combination with PDO threads, in combination with peptides, etc. In combination with Sculptra, in combination, we use PRP in combination with a procedure called profound RF, which is microneedling with radio frequency. And we've got some amazing before and afters of using that combination. So I think the results are pretty remarkable. So I would encourage you to think about other ways you can combine your PRP with other aesthetic procedures. And I'll give you just a couple of sort of examples just so you can see what's possible in case you're not already performing combination therapy. This is all of these, I just have a handful of photos, but these are models whose photos that I have permission to show, and we ask that these not be reproduced or used in any other way though. So this is someone who came to me as a new client. This is her face getting marked that we were about to do the PRP injection along with, I think, 2 syringes of facial filler. And she did that a couple times over the course of 12 months. And I think you can see, you know, what's possible with combination therapy is really remarkable. I will tell you that from picture on the left to picture on the right, there was no change in her weight. So this is not about weight gain or skincare or anything like that. It's primarily restoration of volume, combining PRP, and really just a modest amount of dermal filler in more than one procedure. So I think that's great. This is another good example of someone who has had combination PRP and dermal filler. And again, really beautiful, natural looking results. And I would dare say that I would not be able to go from the photo before to the photo after with dermal filler alone. She had a little Botox in the glabellar or forehead region, but the whole lower face transformation is owing to that combination. Another good example of PRP plus dermal filler, or the so-called vampire facelift. And obviously people are very happy with this kind of result. So I was really glad that we were able to have this webinar tonight. I can definitely say, as you know, a medical spa owner, as a physician for many years, I've certainly learned a lot about interacting with reps. And I put this here because it's like friend and foe, right? Representatives from various companies tend to be attractive. They're polite. They're well dressed. They seem informed. They mean well. They boost up our egos. They treat us often with a lot of respect. They give us some free stuff, which we can then pass on to our patients or clients. So there's a lot of, you know, warm, fuzzy, good stuff going on. But in the back of my head, that's how I see reps. All right. They drank the Kool-Aid, and that's how I think of it in my head. So I have had many a rep over the years, you know, and I'm not saying intentionally looking to be deceptive, but they've basically drank the Kool-Aid. They bought into whatever it is that you know they're offering or promoting, and you know they've been taught to believe, you know, the information that they're giving you, but it's not always based on sound studies or science. It's, you know, they're you know, there's not necessarily a lot backing it up. So I'm very, very careful, especially when it comes to these more complicated medical procedures, about what I take from them in terms of information. So always looking for clinical studies, and a lot of times, you know, even with devices, you ask for the clinical studies and they don't exist. Recently, and I am going to ask Dr. Everts to comment on this, I've been getting in my email box what seems like an epidemic of communications from a variety of companies that want to infer or indicate that there's something that can replace PRP, and I'm seeing that a lot. This one, literally just the other day, you see it's Monday, January 21st. Innovative product to replace PRP, and I couldn't resist. I had to open it, right? So they're promoting a product called AmnioGel. I haven't even really read into it, but again, this was just one of many emails I've been getting about. Here's another one: amnio fluid. Our amnio products are pure. You don't have to cryopreserve them. They're sterile. You don't need to freeze it. In other words, cryopreserve. Our amnio has exosomes. Amnio is covered by insurance. And the bottom, my PRP, Y-Cell Bio has 7 to 9 times the PRP. 15 ml, one tube. My tubes are $59. Could I schedule a time to meet with you? How about no? And here, another one, again, January 3rd. These are all just from this month, and in fact, just in the last few weeks. I saw your website. I want to talk to you about my amniotic fluid product. So I think is where, and literally another one, Amdrop won't leave me alone. So I think it's a good time, since we're talking about PRP and since this amnio craze, if you will, is really hitting in the past year, that perhaps Dr. Everts could talk us through amnion products. Would they add anything? Are they detrimental in any way? Are they not worth the money? I can offer this, though. I did try one particular amnio product for a little while early last year. The cost was about $400 a dose. This was some expensive stuff. It was not something cryopreserved, not something with any living cells, etc. And we gave it a whirl for a few months, and I can't say it did a darn thing. I didn't notice any change in people who opted for the upcharge and got the amnion versus people who didn't. Of course, that's not a clinical study. It's just sort of my subjective. I dabbled with it, and I was underwhelmed. But perhaps, Dr. Everts, we could start to finish up with you, maybe giving us your perspective on whether it makes sense to add anything else to PRP.
Thank you. That's a lot of questions for the remaining 6 minutes, but yeah, I'm glad you brought it up on amnio. You really have to realize what the claims are that are being made by these reps from maybe 10, 12 companies that sell amnio products. And the claims are they contain live cells, they have a huge amount of stem cells, the so-called mesenchymal cells in there. And that's what they have been throwing out to physicians for the last couple of years. When you look at amnio, when you follow just simply PubMed, see where it has been used, what the indications for use are, then you will find 4 or 5 publications looking at the use of amniotic fluid and amniotic tissues for the treatment of chronic wounds. They have been used as a topical agent or as a topical matrix on chronic wounds. And some of them had a positive result and some had no result. Up until now, we do not have any randomized controlled study looking at amniotic in any of the areas. And if you think of where amniotic tissue is coming from, it's coming from babies, from mothers. It needs to be collected and it needs to be processed. The entire processing steps by itself really are creating some problems for cells to survive. So by preserving what's needed, what's mandatory for donor amniotic fluid and tissues to be commercialized into a bottle, there's a whole cascade of safety events, there's a whole cascade of sterilization, a whole cascade of, well, then at the same time maintaining growth factors and stem cells. So long story short, there has been a review presented not too long ago from a very reputable organization from Cornell University by Dr. Lisa Fortier. And she did what we call a proteomic analysis. And it really looks on, well, what kind of proteins are in any fluid? Are they live? What's the viability? And she tested, I believe, 9 different amniotic products. And one of her conclusions was, I'll read it for you. Our results suggest that amnion-derived products do not enact their positive effects by serving as a source of live cells or growth factors. There is a presence in there for a specific protein, and maybe that's a reason why there is some activity, but it has mainly to do with stabilizing the extracellular matrix. It has no effect at all on the proliferation and differentiation for fibroblasts. It has no effect at all on collagen synthesis. So there are a lot of different angles that have been well documented with PRP technology, both in lab setting and clinical settings, as what are the prerequisites in order for PRP to create facial, dermal, skin regeneration, support hair growth. And that's, that's a completely different product than these amniotic products. So we have an on-the-shelf bottle, which is not autologous, is from some kind of a donor that at some stage has been treated, whereas we recently have experienced calamities with one of these amniotic products. It's been all over the news with the FDA. They gave a warning and even a stop note to one of these companies because what was detected after a series of patients were hospitalized with serious illnesses, life-threatening illnesses, because they found features in amniotic fluid. So regulations is another issue which would be too complex to regulate right now, but they do not have an FDA approval for live cells. They got a very, very light approval, as what we call the 361 procedure. And that 361 procedure is a completely different procedure than the one for live cells with PRP and bone marrow, the 351 procedures. So comparing just by what is accepted by FDA from a biologic perspective, PRP versus amniotic, they have two different clearances. In order for amniotic companies to get a clearance for live cells, they need to invest $5 to $10 million at the minimum, I would say, to have these studies demonstrating that they have live cells in their products. So again, there's a lot of things going on. One thing you have to applaud for is they're doing good marketing. But that would be it, I would say, from a cellular perspective. And if you have an approach, ask for a vial. I'm happy to send it to an independent lab and have it tested and get those test results back in your office in seeing whether these claims really have any statute at all to claim what they are claiming at the moment. So that would be my very brief pitch on the amniotic stuff.
Thank you, Dr. Everts, for answering some of those questions. If anyone else has any specific questions they'd like to type in the questions section, we're happy to open it up just for another minute or two over. So please feel free to ask any questions, but I'll move on to the next slide here, where we're just going to let you know about our training options. So specialty med training, we offer online and hands-on training opportunities. So we have different training centers in Peoria, Illinois, Orlando, and Miami, Florida, New York, and Windham, New Hampshire at Dr. Vuich's office. And definitely check out specialtymedtraining.com to see our online training courses. To learn a little bit more. Also, we would just like to say that Gulf Coast Biologics and Dr. Everts will be conducting a training on February 16th. That's going to be in Fort Myers, Florida, and that's all revolving around aesthetics, facial and hair regeneration techniques. So please give us a call. The number is right there below to find out more about registration details. And Dr. Everts, would you like to add anything about the training?
Oh yeah, I'm happy to. So what we're going to do is we have a full day where we have the morning portion on didactics. So we're going to discuss way more in depth the essentials of PRP and the role in aesthetic medicine. We're going to go over more in detail the study as what really is important to measure outcomes. Dr. Vuich is going to share with her clinical experiences on aesthetic biological therapies. We take a break, we have a lunch, And then we get the whole afternoon for 3 hours in 3 workstations, looking at different techniques to microneedling and hair restoration on live models. And Dr. Vuich will inject models for facial injections. So we get all the time in showing you as how to inject at different levels. And the other workstation would be the discussions on devices, make sure you understand the differences among preparation protocols, and furthermore address the different formulations. So the faculty, I'm really happy and proud to announce, is Dr. Vuich and Dr. Thiessen from Canada, and Marcia James as an instructor. And we were awarded with 7 CMEs for the day program. So yeah, that will be it actually. And again, if you have an interest, contact Alicia, and she can set you up with the details for the meeting. Thank you.
Okay, wonderful. Thank you so much. It does look like we just got a last question here. So maybe this is a question for Dr. Vuich, is how much does the platelet counter and the software cost?
I can't answer that. I don't know if Tapley is actually at the meeting. I can't tell who's here. So when I brought it in, basically our phone call, when Tapley and I first spoke, he said, I want to do a lot more than sell you a platelet counter. He then explained that it just so happened they were in the process of developing this software, this whole protocol, this a tool really to try to standardize platelet-rich plasma delivery, or at least certainly understand the dose you're delivering and adjust it as need be, depending on what you're doing. So I didn't actually buy the platelet counter or the computer or such. Those were placed in our medical spa. We do pay for the kits that do the testing. So it's around a couple $100, for each case that we do. So we've just wrapped that into our treatment cost in determining our prices. We do the testing for any male or female sexual wellness. We do it for hair. We do it mostly for the PRP plus dermal filler combinations. Sometimes yes, sometimes no. If I've done one on someone before, I don't necessarily test them every time because I already know where they tend to run roughly. So I can say this. I can say that since we started doing this testing and making these adjustments, we have, and again, we haven't run all the numbers yet, but I can tell you that my sense is that we have a better success rate with patient satisfaction in terms of outcomes. I think it'll be interesting with the hair study to see where that goes, because that's something sort of a little more visually objective sometimes, but versus sexual wellness, where this so much could be at play in terms of results and other things they're using. But I will say it feels like we get a lot fewer calls back from patients saying, that they only got a partial response, or they thought they were going to get more. So it certainly has sort of changed, I think, the quality of our care now that we're documenting. I think the bigger push really that I would make is for anyone involved in research trials in PRP. It would be so great to start to see, regardless of what system you're using for a given study, if people would start actually testing, consistently the platelet count and documenting the dose of the PRP that was injected, the number of cells, not just, we drew the blood, we spun it down, and this is how many mLs we gave, because that doesn't tell us what the actual dose was. So I'd love to see that as a part of the standardization. I think then maybe we could start to be able to compare different systems and different protocols if we're all, at least documenting the dose delivered. So I would have to defer to Bridging Biosciences about where they stand in terms of the Transcend protocol package. If you email me, and my email address should be up there, I can pass it on to Tapley or to Connie, and you know, they can get into the numbers. That doesn't have anything to do with me. And again, I didn't buy it, so I can't tell you what it costs or would cost.
Okay, thank you so much, Dr. Vuich. And I just put up the slide here with Dr. Vuich's email address. She's welcomed any further questions for anyone, so please jot down her email and feel free to send over your questions to her, any clinical questions. And again, please reach out to specialtymedtraining.com, and you can certainly contact us there for training or further questions on our membership or our next upcoming educational webinars. We also love to hear your feedback. If there's something specific you're interested in learning, we'd love to know some of your topics so we can put together some more education around it for you. Does anyone have anything else to add to this at this point? All right, well, I really appreciate everyone's time this evening and running a little bit over, but have a great night, and please reach out to us with any other questions you have. Look forward to seeing you on our next webinar. Have a great night.